Hey, my name is Clay Mayfield, and today I'll be presenting you my final. So let's just jump right into it. The first question is basically walking you through depolarization, muscle contraction of the heart, as well as the electrical signals sent across the heart. So the first thing we have to remember when we're dealing with depolarization is that every cell across the body has an electrical gradient, and this is basically called the resting membrane potential. Now, the RPM is basically determined by the amount of positive ions and negative ions inside of a cell. So when we're taking a look at a cell at rest, we are looking at three important ions. We are basically taking a look at potassium, which there's going to be more potassium inside of the cell than outside of the cell, making it negative at rest. We're going to be taking a look at calcium as well as sodium. Now, both of these have more outside of the cell than inside of the cell. Now, with depolarization, we are basically having a movement of potassium effluxing outside of the cell, a trickle-in of calcium, as well as a trickle-in of sodium. So it's going to basically look like this. You're having calcium and sodium pop into the cell, and then you're having potassium get kicked out of the cell, making the cell more positive and depolarizing the cell. Now, calcium is important, but we'll talk about calcium later on and how that deals with muscle contraction and the force of your heart. Now, getting back into it, so as well as depolarization, we have to remember that cells usually sit around negative 70 millivolts at rest, basically meaning that they are negative and that to depolarize it, it has to become more positive. Now, when this shift occurs, you are basically going to move from 70 millivolts, negative 70 millivolts, to negative 55, which is basically the threshold to start an action potential. Now, an action potential is depolarization. It's going to basically look like this. And you are going to continue to get more positive and more positive until it does kind of end up at zero, and that means everything is balanced out and the action potential has occurred. And then it will start to repolarize, meaning that the ions will then shift back into what it was at resting, basically meaning that calcium and sodium will come back out of the cell, and potassium will then return back into the cell, making the cell more negative. Now, to give you a further breakdown of depolarization as well as action potentials, we're going to take a little further look looking at a chart on how this actually occurs. Okay, so we're going to start off by just drawing a vertical axis and a horizontal axis. We're going to put negative 70 millivolts at the bottom because that is where usually the cells are at rest. Now, next marker will be negative 55 millivolts, as this is when the threshold is hit to start the action potential. It has to increase by about 15 before the action potential can get kicked off and really start. The next marker will be 0 because 0 is important, as both outside and inside of the cell are at a balanced charge. And the action potential will hit its peak around plus 40 millivolts. So positive 40 millivolts is when it will hit that peak action potential, and it occurs. So we first start off, you're starting to have potassium move outside of the cell, calcium as well as sodium move inside of the cell. So we start to see an increase going from negative to more positive. We see an increase till it hits negative 55, so it's a steady increase, and then it just takes off. So it takes off, hits plus 40 millivolts, where this is where the action potential will occur. And then after the action potential has occurred, it starts to repolarize, going back to a more negative state instead of positive. And sometimes cells can hit below negative 70 millivolts because of basically the influx of potassium and how much potassium is coming back, or how much potassium is coming back into the cell. So it can hit down below negative 70 and hit negative 90 millivolts. Now, this is called hyperpolarization, and this occurs every now and then, but you usually want the action potential to go back down to negative 55, that threshold, so another action potential can occur and your cells can continue to work and keep you alive. So like I said, when we're taking a look at this, start off with negative 70 millivolts, move your way up to negative 55, which is going to be your threshold. Then we go up to 0, which basically means that it is balanced. Negative and positively, it is balanced. The cell is just at equilibrium. And then we move all the way up till it hits its peak at about positive 40 millivolts. meaning that an action potential is occurring at this peak, where it will then, after the action potential, ions are going to shift again, repolarizing the cell, sometimes going into hyperpolarization or negative 90 millivolts. And then once again, cells will kick off, fire that electrical gradient. The resting membrane potential will then become more positive instead of negative, depolarizing all the way to the action potential, and then repolarizing, sometimes causing hyper repolarization all the way until it hits about negative 55 or back down to negative 70 at its resting state, and then it will kick off again. So like I was saying before, the calcium will come down the L-type channel to T-tubule. It will be sensed by the calcium sensing feet. This sends a signal to the sacroplasmic reticulum, which will then kick off a calcium coming from the sacroplasmic reticulum and start this whole process of the actin-myosin cross bridge. Now, the actin-myosin cross bridge is basically your sarcomeres, and how your sarcomeres will get the greatest stretch to cause the greatest force or contraction for those heart muscles. Now, calcium, once it starts to mess with this, it will bind to troponin C, which will then cause it to unbind, which will cause tropomyosin to unbind from actin to allow actin and myosin to form a cross bridge and to kick off this whole greatest stretch, or the Frank-Starling mechanism. So like I was saying before, the calcium will travel down the T-tubule, where it will be sensed by calcium sensing feet hanging off the side of the T-tubule. This will send a signal to the sacroplasmic reticulum, which will then cause a release of calcium from the SR, so it can freely move about the cell and bind with troponin C, which will basically cause the tropomyosin to move and unbind from the actin, allowing myosin and actin to bind together to kick off a contraction or the greatest stretch. If you're part of the Frank-Starling mechanism, you get a great stretch until a certain point. We'll probably go ahead and talk about that later. But like I said, calcium binds the troponin C, which will then make the tropomyosin move away from the actin and allow the myosin and actin to bind together, causing a pulling mechanism and the contraction of that muscle. Now, it is important also to remember, while this is occurring, ADP, there's something called ADP and an inorganic phosphate that are dropped basically due to the myosin and actin binding. ATP will also be formed. So out of this, ADP and inorganic phosphate form ATP. ATP will then bind to the myosin head, releasing actin at the end of the greatest stretch or the end of the contraction. And it releases from the myosin head, or it attaches to the myosin head, releases the actin, and then the ATP will then break down into ADP and inorganic phosphate to be used again, only if calcium is in the cell or present. That's the only time the ADP and inorganic phosphate inside the cell are being used to basically stop the contraction after it has already caused this greatest stretch, because we do not want the cell to overexert itself or to kind of stretch into a point where it breaks and it's not going to get a full contraction every time. So now that we've taken a look at both muscle contraction and depolarization of the heart, we are going to look at how the signal is sent across the heart. Now, it's good to remember that the heart is basically like a potato sitting this way in your chest. And it has 4 different parts to it. So we have a right atrium, or 2 atrium and 2 ventricles. So you have a right atrium, a left atrium, a right ventricle, and a left ventricle, sort of looking like this. Now, the right atrium is the most important part in this process in getting that signal sent across the heart. So within the right atrium, you have something called a SA node, or the sinoarterial node, and this is known as the pacemaker. Basically sets the pace of your heart, or how much your heart is contracting, or the beats per minute it is beating. So the SA node is called the pacemaker, and is going to be setting your heart to about 60 to 100 beats per minute. Now, when the electrical signal is sent, it is going to basically travel across the atrium, where it will eventually reach the AV node. Now, the AV node is your atrial ventricular node. And this one basically has a beats per minute of 50. So if your SA node is not working or not firing properly, at least you know you will still be able to beat your heart 50 beats per minute. Now what the AV node is going to do is cause a delay. It's cause a delay in this electrical signal so that the ventricles and the atrium are not contracting at the same time, because we want it to fill, and then we want to be able to contract and shoot that blood out to the lungs or the rest of the body, wherever it is coming from or going to. So yeah, once the electrical signal reaches the AV node, is going to hit a delay and hit a space where all it is dead myocardial cells, to also help with that delay so that the electrical signal does not just go atrium, ventricle, ventricle immediately. We have about a 0.08 second delay to allow the ventricles to fill and to give time for the atrium to contract before contracting the ventricles. Now, this electrical signal is then going to travel down what is known as the bundle of His. So the bundle of His here, it's going to travel down the bundle of His, where it then reaches bundle branches as well, coming down, and then it hits Purkinje fibers going up. So now you can see that we have already hit the 2 atrium at top. Once the SA node fires, it travels across the right atrium and left atrium, where it will eventually hit the AV node and a lot of dead myocardial tissue. And then from the AV node, it will go down the bundle of His to bundle branches, and then back up through the Purkinje fiber, so that every part of the ventricle is getting that electrical signal and basically saying we need this to contract now to push the blood out to the rest of the body. Again, just to reiterate, just more of a simple breakdown, or a little quick breakdown. Remember, SA node fires off, your pacemaker fires, travels across right and left atrium, kind of going at a diagonal, or at about a diagonal direction, and it is moving from cell to cell. Now it is going to hit something called the AV node, which will basically cause a delay, allowing the ventricles to fill up with blood before contracting, because if we contract both atrium and ventricles at the same time, then they would slap each other and you wouldn't get a good contraction, nor honestly any blood moving out of the heart. So once it hits AV node, it is going to run down the bundle of His, then to the bundle branches, where it will meet the Purkinje fibers and be sent up through the ventricles, allowing the ventricles to contract and push that blood out into the body. So now that we have talked about contraction of the heart muscles, depolarization, and how the signal is sent across the heart and how an EKG can relate to that, let's shift our focus towards more of the pathology side of the heart. Now, some people, as they get older, really anytime during their life, can experience something called a myocardial infarction. Now, this can be a heart attack, or better known as a heart failure. And with heart failure, you have 2 types of heart failure. And one's a little bit better than the other, but they're still both pretty bad. So you have HFrEF, which is heart failure with reserved ejection fraction, or better known as systolic failure. Now, this systolic failure is basically caused because of changes in cellular signal transduction, as well as problems with the excitation contraction coupling process. Now, this will overall decrease or cause a downward spike in your Frank-Starling mechanism. Now, Frank-Starling mechanism is basically how is the greatest stretch for your sacromeres that occurs during the preload. So the Frank-Starling mechanism basically says that your sacromeres stretch and stretch and stretch to a point where they can no longer stretch, and they become exhausted and kind of break down, leading to a decrease in stroke volume, leading to a decrease in inotropy, and leading to an overall decrease in contraction and how forceful that contraction is to push that blood out to the rest of the body. Now, this condition can progress, and basically meaning that the heart's ability to compensate for this problem will start to diminish as you prolong, or as this process or this condition is prolonged. Sacromeres will start to adapt, and by adapting, it means they will dilate and add more sacromeres to the series so that it can cause a better contraction. Now, the sacromeres can only do this for a certain amount of time until the body is exhausted and those cells are exhausted, and it can no longer produce that greatest stretch nor be able to adapt by adding more sacromeres to the series. This generally occurs in the ventricles because it remodels and adds more sacromeres into the series. So yeah, I mean, that's basically about it for HFrEF. Now let's take a look at the second type of heart failure that patients usually have, and that is going to be HFpEF, or heart rate with preserved ejection fraction, or better yet, known as diastolic failure. Now, with this type of heart failure, it is going to have to deal with more on the ventricles filling up and how that is impaired. While the ejection fraction is not really messed with, basically meaning that the volume of blood that it is pumping out, that is usually going to be about 50% or more, so a lot better than HFrEF, which is not even close to that percentage that you're going to be able to pump out. So that kind of is why HFpEF is a little bit better. Now, both of them are conditions and pathologies that can ultimately kill you, either when it occurs or later on in your life, so it is something that you need to be watching out for. Now, with HFpEF, in these cases, like I mentioned earlier, you're going to have about 50% or more ejection fraction, meaning that you're still getting about 50% or more of that blood out to the rest of the body. Now, in this process, the left ventricle specifically loses its ability to relax normally because of this process, and the muscle has to become stiff. Now, when the muscle becomes stiff, the heart cannot fill blood properly during resting periods between each beat. Now, diastolic function involves the abnormalities of active ventricular stiffness and higher diastolic pressures. These pressures are going to be transmitted through arterial and pulmonary venous systems, reducing your lung capacity as well. A combination of decreased lung capacity as well as decrease in cardiac output is going to lead to these symptoms. So basically, yeah, so it's going to have a decrease in ventricular compliance, it's going to have an impaired relaxation, a decrease in relaxation or lusitropy, as well as stiffness of the heart. So it is going to decrease your inotropy, or the contraction of that heart overall. Now, the body does compensate with both forms of heart failure, but with HFpEF specifically, with having impaired ventricles or impaired filling within the ventricles, this can lead to ventricle failure. Now, when this leads to ventricle failure, I'll draw this out a little bit. So, ventricle failure occurs. Ventricle fail, right? Ventricle failure occurs, and so basically, this is going to lead to a decrease in cardiac output, which will thus lead to a decrease in arterial pressure, as you are not pumping out nor getting a strong enough contraction due to ventricle incompliance, or a decrease in ventricle compliance, as well as a impaired ventricle filling. And stiffness of the heart, you're not going to get as much as a contraction, which leads to a decrease in the overall arterial pressure. Now, your body is going to start to kind of compensate for this by increasing sympathetic nervous system activation, as well as the output, or the further causes from the increase in sympathetic activation. Now, this is going to increase a couple of things. This is going to increase angiotensin 2. It's going to increase aldosterone, as well as a vasopressin, to basically start to increase that cardiac output again, or the arterial pressure, as well as all of these things that I just said lead to an increase in blood volume, as well as an increase in venous tone, leading to an overall increase in venous pressure. So it needs to increase that venous pressure. Since the arterial pressure has already dropped so much, it is going to compensate by increasing the venous pressure. Now, increasing venous pressure can lead to some complications, such as like pulmonary edema or systemic edema, meaning that the blood is going to be kind of sitting in one particular spot and area, causing inflammation and a lot of bad bacteria to be just sitting within that spot. So after this venous pressure is being increased, now that you have the risk of pulmonary edema, systemic edema, which is not good, it is then going to basically cause peptides to increase within the atrium, so that it can increase systemic vascular resistance, so that we can now start to kind of have constriction and allow arterial pressure to begin to build up, as well as to allow cardiac output to increase. Overall, the body does compensate for both of these, but more so HFpEF than HFrEF. Like I said before, HFpEF, you're still going to be getting a lot more blood volume out into the body rather than HFrEF. Or, yeah, rather than HFrEF, because HFrEF is going to decrease your ejection fraction below 50%, where HFpEF is going to keep it at about 50. So now that I've talked about heart failure and the two types of heart failure and how this does affect the individual and the changes that occur within the body, let's talk about how we can see this in real time and see how the heart is performing. So there are a couple of different types of ways, but the one I'm going to focus on for this final is an MRI. Now, an MRI is mainly a magnetic resonance imaging machine that kind of takes a snapshot of mainly just soft tissues, because it really only affects soft tissues. Now, it also does measure the pliability of organs, but that's a different topic for another day. So an MRI, magnetic resonance imaging, first thing to note about this, it is a very safe machine. There is no radiation involved within this process. It mainly uses radio waves. And so before you even hop in the machine, there are things to remember. You got to watch out for tattoos. I think tattoos have to be covered up. You have to remove any metals on your body, like jewelry, watches, rings. Keep your cell phone away from this, because it is a very big magnet as well as a very powerful magnet. And so, yeah, so once you got all that done, you hop into the machine. You're going to enter something called a bore. Now, a bore is basically the magnet. And the magnet, what this is going to do is cause the atoms within your body. Now, your body is made up of a bunch of different atoms. And within each atom, they have north and south pole, basically meaning that they have a positive as well as a negative charge. Now, when getting into the bore, this magnet is going to align all of your atoms within your body pointing in one direction. And what this machine is going to do is shoot a radio wave through your body and cause these atoms to unalign, and so basically scatter about as they were before you hopped into the machine. And then once the radio wave is completely done and it is turned off and been shot through your body, your atoms will realign once again. So basically, it's going to do this. And once they realign, it takes a snapshot of your, taking a snapshot of your heart or any soft tissue or organ that you were trying to take a snapshot of and see. So you start off with a bunch of atoms, right? Got a bunch of atoms in your body. You're starting off, and each one has a positive as well as a negative. So this one has a positive, this one has a negative, this one has a positive, this one has a negative. All of them do. So as you enter the machine, what this is going to do is cause these atoms to align in one direction, basically pointing this way. I believe it aligns it by positive, so positive is going to be pointing, I believe, upward, or yeah, some type of direction like that. Now, once the radio waves come in, hit it, this causes all these aligned atoms to go back into this, basically allowing us to take a snapshot or forming a picture of the heart or the organ being looked at. So for the final question for this video final, what I chose was essay prompt number 3, and it's basically talking about how a patient reports into the facility. He's 56 years old. He's had a myocardial infarction, and he has just had a bypass surgery. And basically wants me to explain the precautions to take when dealing with this patient. You know, how do I expect exercise to be tolerated, as well as exercise's effects on the cardiovascular system. Now, the first thing to realize in this, that it is important to see that the patient is currently on, one, has had myocardial infarction, 2, has had bypass, and is currently on diuretics as well as an emergency vasodilator drug. This is, you need to very much take this into consideration before even beginning workout, and build a program around that and how these drugs are going to affect it. So precautions to take. The first thing to know is warning signs of another heart attack. We do not want to start exercise not knowing anything about, symptoms of a heart attack. We want the patient to be safe, we want them to be comfortable, and we want to know what's going on. So knowing symptoms such as, you know, shortness of breath or grayish coloration of the skin or just cold sweat or upper and abdominal discomfort is something to keep in mind. Now, the second thing is, are there any other signs and symptoms? Are there any other diseases or pathologies that this patient has that he's just formed? So having a conversation and communicating with them on that end, just making sure everything else is checked out. Now, the third thing to take into consideration is the diuretic this patient is on. Like I mentioned earlier, you need to build a program around the condition that he is in as well as the medication he is on. Now, diuretics are going to decrease your preload, basically reducing the blood volume coming through the right atrium as well as increasing liquid excretion. So the precaution here is that since he is going to be excreting a lot more liquids, you need to watch out for dehydration. You need to explain to him the symptoms of dehydration and have him communicate when he's feeling, you know, nauseous or dizzy, or, you know, having that kind of flushed color coming out of the skin. And so the diuretic could lead to some electrolytes as well as just imbalances within these cells. So knowing these warning signs will come in handy. Now, the second drug that he is on is an emergency vasodilator. And so what this is going to basically do is decrease the afterload. So the second drug we're going to talk about is that this patient is on is an emergency dilator, or emergency vasodilator, basically meaning that is in case that he does start experiencing signs and symptoms of a heart attack or he's having a heart attack, he can take this drug and it immediately increases the lumen size to allow more blood to get into the heart and to the rest of the body, hopefully kind of decreasing the severity of heart failure or myocardial infarction. So basically, things to note that this vasodilator does, it is going to basically decrease your afterload. Exercise does vasoconstrict arteries or the lumen, so it will decrease. Well, it's not going to decrease it, but exercise decreases or vasoconstricts. So this drug is basically going to open up that lumen. With this, like I said, immediately opens up the lumen to possible pressure changes. Now, this is big. So before he takes this drug, is probably going to be vasoconstriction occurring, which basically means that mean arterial pressure and overall SVR, or systemic vascular resistance, is going to be increasing, as well as pressure within these arterioles or arteries or veins and venules. Pressure will be high, and so what happens when he takes this drug is the pressure is going to have a dramatic shift. It's going to be from high pressure automatically dropping to low pressure. So he's going to probably have high blood pressure and then immediately drop into low blood pressure. Now, the precaution to take here is be on the lookout for that. We do not want him passing out and then hitting his head or further injuring himself or causing another heart attack in this instance because of pressure changes within this. So if he does pass out, or even before that, we need to make sure that we do have fall protection for this individual. Now, we're going to go over a few of the effects that exercise has on the body. One being that exercise increases the venous return, leading to an increase in cardiac output by preventing a fall in preload, which basically means it's going to increase venous return or blood flow coming back. And this will increase the cardiac output due to basically preventing a fall in the preload or any decrease in the stretch or contraction that the heart has. Now, the increases in cardiac output comes from the increase in venous return, but as well as the increase in heart rate or the increase in sympathetic activity with a decrease in parasympathetic activity, because cardiac output is CO or Q equals heart rate times stroke volume. Now, stroke volume is where you're going to have your preload, contractility, and afterload. Like I said earlier, with the preload, it is going to prevent a drop in preload. Otherwise, that would be caused by heart rate. So systemic vascular resistance is going to decrease when exercise occurs, so that your body can allow more blood to get through, more oxygen, more minerals, so that the active muscle, the working muscle, as well as the heart is getting what it needs. So SVR basically decreases because of metabolic vasodilation within the active muscle, meaning that Those lumen sizes are getting bigger, and we are getting more blood to the active muscle. Basically, skin vasodilation as well. The vessels running through your skin are going to vasodilate, open up more to allow more blood to get in, as well as a vasoconstriction of your gastro system, your renal system, and non-active muscles. So your body is going to cut off things that it does not necessarily need to get more blood to, so that it can push more blood to the active muscle, so that you're getting more nutrients, more minerals, more oxygen, so that muscle does not get exhausted, and that muscle does not experience any fatigue or early onset fatigue. Now, systemic vascular resistance decreases because of the vasodilation. But let's just hit a few more things on mean arterial pressure, cardiac output, heart rate, all those things. So when we're looking at mean arterial pressure, this increases because of cardiac output, like I stated earlier. Now, cardiac output is the reason why mean arterial pressure is going to increase, is because cardiac output is increasing more than SVR is decreasing. Now, cardiac output and heart rate are going to increase almost proportionately as you increase the workload or the intensity of the workout, and then stroke volume kind of plateaus once you start to get into the high range of heart rates. Now let's take a shift and look at the final part of this question, and how exercise will be tolerated in this individual. Now, first off, I want to say it depends on the individual. It depends on the condition, the severity of the infarction or the heart attack they just had. In this instance, it also depends on whether or not the bypass surgery is truly working and how well that is working. As well as things to look out for when expecting exercise out of this individual is their cardiac rehab, how well they're progressing through that, maybe the treatment plan that is already put in place for them, how they've been following it, how they've been doing the right things, eating the right things. So exercise is expected to be tolerated well or not, depending on these factors. But in this instance, I would have to say that while there wasn't a lot of information given about the client, what I can basically tell off of this, that exercise is to be expected to be low and keep it low intensity, keep workload to a minimal, start them off very nice and light, very easy, maybe a brisk walk, or get on the treadmill and just have them walk, or have them start climbing stairs just to see how well they are progressing, or where their condition is at. Exercise, in my opinion, is going to be expected to be low for a little bit until they can progress up, and this is basically because the preload within the individual will be low, as well as the blood pressure within the individual is going to be low. So we're not getting as forceful of a contraction, we're not getting as great as a stretch for the Frank Starling mechanism, because it probably has already been exhausted, as well as he's going to have low blood pressure, and that's basically due to the vasodilator drug that he is taking, as well as the diuretics. So the diuretics is going to lower the preload, and then the vasodilator is going to be the one that is lowering the BP. So these are things to look out for. But yeah, I expect exercise out of this individual to be low until we can progress. Our low progression is going to take a while for him to progress up and do things. So yeah, so that is the end of my video final. I hope you enjoyed. I hope I got the information correct. I feel like I did pretty well on it. But thank you for your time, and I hope you have a great summer.